It is still, Vivek, very difficult thing to get the... And how frequently you do your prenatal NIPT RH antigen? Are you comfortable with that report?
Yeah, so far we've had quite okay results. I mean, we do it only, as I said, after the triaging, if she has only anti-D antibodies. If there's one more antibody, we don't do it because it makes no sense.
No sense.
So if the mother has only anti-D antibodies and you're suspecting the fetus could be negative because the husband might be heterozygous, in such cases you might probably do it. Otherwise,
do you routinely go for the husband's zygosity?
Not routinely, because quite expensive. We don't do it.
Yes.
But we were doing it as part of a study. So then we were comfortable. So we knew exactly if the husband is homozygous, then you don't need the NIPT, because NIPT for rhesus is 16,000 rupees. It's quite costly.
Yes.
So we will select our mothers, triage them, and you think that there's only anti-D antibody, then we offer the NIPT.
We are running short of time. There are multiple questions from my side also. We will discuss, and I request...
would like to give one suggestion, D'Pankar. Next time, such good speakers, you should give us a take-home message from them, no? So that we keep it.
They are
with
already
us.
giving take-home message. There are too much messages to take home.
And I request D'Pankar sir to please felicitate all of them. Professor Geeta Goin madam and Dr. Professor Binu Khushwa madam to please join us on the stage.
You are felicitated.
Felicitate करना उन लोग को बोल दो. I request the panelists also to join us on the stage. Dr. Sneha Chaube madam, Dr. Nidhi Jain, Dr. Kaveri Shaw, Dr. Shelja Soni, Dr. Deepika Devani and Dr. Trisha Nayak.
Everyone, at the outset, I am very thankful to D'Pankar Banerji sir and the organizing team of FetusCon2024, and I am especially privileged to be, sharing this podium with Geeta Goin madam. And so I would start the panel with the introduction, a short introduction of all the panelists. So these are the panelists: Dr. Sneha Chaube madam, Dr. Kaveri Shaw, Dr. Nidhi Jain, Dr. Shelja Soni, Dr. Deepika Devani and Dr. Trisha Nayak. So I think we would straight away, yeah, ma'am, please introduce the topic.
Thank you so much. And it was wonderful hearing all the lectures. And you, Dr. Krishnan, put us to shame saying that you have lost your hair. You wanted to make all of us conscious, but you have really kept up with the Kerala side and kept all your hair. And thank you, Dr. D'Pankar sir, for this beautiful panel. It's always been a very wonderful experience learning. Every time I see these sort of very specialized conferences, I wish I could go back in time. I could again become a postgraduate, sit in the classes, read, and just read and read and read and enjoy the reading. So today we are here to discuss fetal infections. What I'll think is, I'll be just talking to the panelists and the wonderful audience, and you can just flip through the...
Yeah, sure.
Okay. So today we are here to discuss the torch infections. Now, when we speak of these infections, we know that we are talking a very specific class of infections that essentially affects the fetus when in utero, and sometimes when the fetus is born, that child could be born with those infections. Why are these infections important? Epidemiologically, if you look at it, around 5% of pregnant women would get these infections. What is important to realize is, of these 5%, almost 70% of all the infections that the lady would have during the course of the pregnancy is going to be asymptomatic. The infections we are talking about is, we know, toxoplasmosis. The other infections which commonly we have as the syphilis, the parvovirus 29 infection, the other viral infections, any viral infection for that matter. The rubella infection comes for R, then the cytomegalovirus, and finally the herpes infection. Now, of all these infections, except for herpes, all the infections rather would be very important when happening earlier in the course of pregnancy than in the later course of pregnancy. It is only the herpes virus which gets transmitted at the end of the pregnancy during the time that the baby is passing through the vagina and coming into the outside world. Now here I am reminded that we often see these infections advised on the prescription slips. Now, they are wonderful tests to be done, provided you understand the importance of why they are being done and you actually interpret the results of why they are done. So, I'll just give you a small example before we proceed with the case scenarios, and that will help you understand how these torch infections are important. So I have taken this scenario from France, where the higher health authorities, as they are called, have a guideline that at 6 weeks, every pregnant woman would have to be tested for the rubella IgG and the toxoplasma IgG and IgM. Okay? So a lady who's 14 weeks pregnant, she comes to the hospital and she was tested at 6 weeks and found to be IgG negative for rubella and IgG positive for toxoplasma and IgM also positive for toxoplasma. Okay? When a detailed history is taken, now this lady gives a history that at 5 weeks she had rashes, and these rashes essentially were treated as allergic rashes, no other symptoms. Now, because this lady is IgG and IgM positive for toxoplasma, so she is immediately started on spiramycin and an avidity testing is ended. Now, what is this avidity testing? Avidity testing is the testing of affection between the antibody and the antigen, right? How much love that antibody has for that antigen. So as the relationship between that antigen and antibody ages, or in other words, as the time passes, the strength of attraction between that antibody and antigen increases. And there are predetermined graphs which can actually say that if the avidity is, antibody avidity is this much, when the infection is likely to be. So an avidity test is ordered for this toxoplasma infection and the avidity comes to be 78%, say. And on the graph, that 78% translates to an infection that has happened 5 to 6 months earlier. So what is the immediate interpretation? That this lady actually had an infection, but that was predating the pregnancy. So the spiramycin is stopped because this baby is, and this pregnancy is not going to be benefited by the spiramycin. Now, as a protocol, if a woman tests negative for toxoplasma or rubella in France, they have to be offered a repeat testing after 10 weeks and by 20 weeks. So this lady comes back again at 16 weeks and she is tested for rubella, right? Now her rubella turns out to be positive. When the rubella turns out to be positive, a detailed early target scan or anomaly scan is done and no anomalies are actually detected. So when the rubella comes out to be positive, an avidity test is sent. Now, most of the times for rubella, the avidity is expressed by percentage. So if the percentage is less than 30, it is a low avidity, means that the infection is new. Between 30 and 70, very low, and between 30 and 70 it is low, between 70 and 90 it is moderate, and over 90 it is very high avidity. So when this avidity testing is ordered, it comes out to be moderate. And when it is charted on the graph, it comes out that this lady had that rubella infection at around the time when she had the rashes at 5 weeks, which was actually treated as an allergic rash. So this lady by that time is then subjected to an amniocentesis and a sampling of the cord blood. Now the baby comes out to be positive for rubella IgG. PCR is done, rubella is positive. At 19 weeks, a detailed scan is again done, and at this point of time, we discover a cyst in the brain, calcification, microphthalmia, and a large echogenic focus in the heart. Obviously, the couple is counseled that the child is affected by rubella, and the couple chooses to terminate the pregnancy. Now, that is the beauty of fetal medicine, and that is the beauty of TORCH. The beauty does not lie in just advising rubella because somebody has had a recent abortion. What are you going to do with that test? So in the course of the subsequent cases that we are going to discuss, I think these scenarios and these situations are going to become clearer and clearer. Okay, Binu, now your turn.
Thank you, ma'am. So we'll now be starting with the actual case scenarios. So our first case is a Gravida 2 Para 1 L1 with previous cesarean section done for breech has come to us at 14 weeks of pregnancy with a history of fever with malaria 4 weeks back. So on TORCH testing, she is IgG negative and IgM positive for toxoplasmosis. So this case is for Dr. Sneha Chaube. So madam, how are we going to confirm the diagnosis that she is actually having toxoplasmosis, that is recent one?
I think a single test does not confirm the toxoplasmosis. So we have to repeat the test whether after 2 weeks, whether some seroconversion is taking place or not. And if some seroconversion is taking place, there is 2 to 4-fold increase in level of IgG, then we can go for avidity testing. And depending on test, further tests will be advised.
Yeah, very rightly said, madam. I would only like to add that the repeat testing is to be done at 3 to 4 weeks interval actually, and this only IgM negative positivity is not an indication for recent infection because the IgM may persist for years after the infection. So you have to actually see either the seroconversion or the increase in level of IgM or doing the avidity test. As Guin madam told, if the avidity is low, that tells that the infection is recent one, and if it is high, then it tells that the infection is old, more than 3 to 4 months old. So in that case, we do not need to do anything, but here the confirmation has been done, the seroconversion has been seen. So how are you going to counsel the lady that what are the risk of transmission in this women to the fetus?
If the avidity is high, then we can follow her up with routine sonography. But if it is low, then we can advise her that fetus might be affected and we can go for an amnio PCR testing. And further course will be decided according to those reports.
Exactly, ma'am. And the most important thing is that you need to tell the patient or the women that the risk of transmission although increases with the increase in the gestational age, but the affection of the baby is most when it happens in first trimester. So that is the most important point that you need to tell the couple. So here, what would you do if you like say that she is having toxoplasmosis infection and that is before 18 weeks? Are you going to do something, or you are just going to wait for the confirmatory test to be done beyond 18 weeks?
After conversion, we should wait for at least 6 weeks, and after 18 weeks, as fetal urine does not show the...
So the confirmatory test here can only be done after 18 weeks because the toxoplasmosis antigen PCR, that DNA is secreted only after when the diuresis is prominent in fetus. That happens only after 18 weeks. So what would you do now? She has come to you at 14 weeks. You know that she is having toxoplasmosis infection. Are you going to do something in first trimester also? I mean before 18 weeks?
Before 18 weeks, we should have all other tests to exclude any genetic issues like...
that routine thing, yes, we will all be doing. But the most important thing, as Madam tell, is the initiation of spiramycin therapy. That is very important. It is 1 gram 3 times a day. It basically reduces the transmission through the placenta. Yes. And also the main thing is that it binds to the antigen, the toxoplasmosis antigen. So it decreases the load. So the transmission would be lower. So until you have this, you don't have to wait for the confirmatory test to start the treatment. You have to start the spiramycin treatment as soon as the toxoplasmosis infection is confirmed. So once we are beyond 18 weeks and we have done the amniocentesis, in that also if the PCR is positive, the treatment of choice actually is pyrimethamine and sulfadiazine sulfadoxin combination. But as this may cause embryopathy, we do not give it in first trimester. But this is the drug of choice which actually reduces the chances of fetal infection and also the severity of the infection. So I think that concludes our first case. And also very importantly, these all babies need to be monitored very carefully postnatally also, because most of them are asymptomatic at birth. So you need to follow them up with the neurological sequelae with the help of ultrasonology and the MRI scan. Okay. So I would now request Gwyn Madam to...
the second question.
Okay, right. So the second question is also about the toxoplasmosis only. This is for Dr. Kaveri Shah. She is a primary gravida patient who has come to us now at 26 weeks. Although she had an anomaly scan at 21 weeks and that showed intracranial calcification, but she was just roaming around. She was told this. She did not do. She came to us at 26 weeks and her 21 weeks scan showed early onset FGR with normal anti-scan at 13 weeks. She has now come to you for consultation. So what is the role of torch testing now? Would you be doing it?
Yes, I will go ahead with torch testing because the features of 21-week scan is showing more of diagnostic for intracranial calcifications with early IUGR, more in the favor of toxoplasmosis. So first I will go with the torch testing and I will go ahead with the IgG values, and I will ask for further management, like we can offer her for the amniocentesis, because right now she is in 26 weeks and the amniocentesis will conclude the diagnosis for this as well. So I will ask first with the torch.
So Kaveri, what I just want to know, you wanted to do the torch because you needed the result for counseling the patient, or you needed something to do with the management?
Ma'am, I want it for the management part as well, because IgG positive, if it is there, means it is the, anyways it is 21 week intracranial calcifications are there. So it is going in helping us for concluding the diagnosis, and we can evident that we have to confirm with the amniocentesis. So for the amniocentesis part, I can better counsel the patient.
The patient is 26 weeks, I think, and you have found, this is 26 weeks, and you have found that the IgG is increased fourfold, right? So did you have the baseline IgG?
No, ma'am,
No,
we didn't have.
You didn't have the baseline IgG. So actually, that single IgG is not going to tell you anything. So if the IgG comes out to be positive, so and IgM is negative, so what do you do? What do you do?
Ma'am, with IgG positive, it means patient is having avidity.
First, I'm not crossing you. What I want to know is that this is the first time you're doing the IgG and it has come out to be positive. Now, how do you decide that this is the infection that happened in the course of this pregnancy and not earlier?
Avidity testing.
Okay, so you would go for the avidity testing. Now she's 26 weeks. Suppose the avidity testing comes out to be low. Okay, then what?
Then also I have to go ahead with the, since the features of USG I have to see.
Okay. So since the USG features are there, vis-a-vis calcification and all, you want to go ahead with the
detailed
scanning, and you want to go with the chordocentesis. Now at this point, I just want to add something. When I was reading all of this up and going through the literature, I found that the Coxsackie virus is now an emerging virus. And what is to be remembered is of all these viruses, they can be transmitted by saliva, by blood, and by sexual contact and all. Coxsackie virus, unfortunately, is transmitted by the bite of the Aedes mosquito. And we know how frequent that is. And we know that its presentation is almost like dengue fever, and it can lead to lot of neurological complications in the mother and the fetus, including a presentation like the Guillain-Barré syndrome. And when I was reading up this virus, I realized the number of patients in medical college, us being tertiary referral hospital, you will find that at any given point of time, we have 4 or 5 patients who are admitted with high-grade fever, pregnancy, with fetal mishaps. And we have, in the very recent past, had 2 patients, one presenting with two presenting with Guillain-Barré, one presenting with vocal cord palsy, and eventually succumbing to respiratory failure. So this virus has to be kept in mind, right? Because we are in Jabalpur living in a dengue endemic area, right? And we are thinking of all these big things, and we are forgetting out a virus which could be more harmful and could cause all these more frequently than the toxoplasma or any other virus. So I think
actually I would only like to add in for this case that when you have specific USG features available, you really don't need to do a torch testing in this patient because she has come to you at 26 weeks. You don't have much time, right? So you can straight away go for a amniocentesis in this case and find out if PCR, she's positive for PCR or not. Start her with that sulfadioxin and pyrimethamine combination. But yes, counsel the lady, because as the calcifications are already there, the affection, the chances of affection of fetus are very high, right? You need to counsel about everything on this. And then because of our amended MTP Act, you have the option of termination available. So please, everyone who are there on MTP boards, the torch consequences, the toxoplasmosis consequences, the CMV consequences can be very serious in baby, and that may appear later on. So please do not be like the infection may be there, may not be there, because you would never be knowing what are the exact chances of affection of the baby. So you can always allow the MTP to happen to save the parents from that trauma that they have to undergo, right? So please use this amended MTP Act.
So with these USG findings, I would personally probably not order a torch.
Yes.
I would not order an avidity because I am not going to gain much, because this baby is, it is not like that I want to confirm the diagnosis. In case it is 26 weeks and the patient wants a termination, but suppose it is 30 weeks and the patient wants a termination, then probably I'll go for the torch, I'll go for the avidity, because I will have to go and prove it before the court that this is the reason why I feel that this lady might need a permission for termination at 30 weeks.
Yes, and also whenever you are doing the amniocentesis for these kind of ultrasonological features, the sample is not only to be sent for the torch infections, but for the karyotyping also, right? It is not that once you find that, okay, this torch testing is, this PCR is negative, now we'll go for a repeat amniocentesis. With that sample only, you are supposed to, because here there are features of early FGR also, and there are so many ultrasonological features also, so always send the sample for karyotyping also. Nowadays we would prefer microarray, actually, not the simple karyotyping.
And even if the mother and the baby did have the infection can come effect, but most of the times it is self-limiting, so it is going to cure off. So it is not necessary that at the point you are testing, you are going to diagnose that the infection is happening at that particular moment. So whether you need the torch or not has to be very, very well thought out, because except for AIDS, not even HIV, except for AIDS and syphilis, all of these torch infections are self-limiting. And if I do it today, I do nothing but to explain it to the parents. Other than that, they might not have much significance vis-a-vis the subsequent pregnancy.
Right. So last point was about the obstetrics management. In all torch infections except for the herpes virus infection, active infection, the obstetrics management does not change. It is not an indication for cesarean section. It is not an indication for early induction or whatever. Right. So we'll come to our next case now. Yes. So would you like to take this case, ma'am? Yeah, okay. So she is gravida 2, abortion 1, 13 weeks gestational age, fever with rash and malaise for last 3 days, and on testing she is rubella IgM positive with anti-scan normal. This question is to Dr. Nidhi Jain.
It is rubella IgM positive, so it is a recent rubella infection, and it is as...
Would the single test tell you?
Nidhi, I don't agree at that point that rubella IgM positive is a recent scan.
Single IgM positive is not an indicator for recent
IgM
infection.
Is not, we have to confirm after
take
2
home
weeks.
Message, first take home message.
So the first take home message is that while in most cases IgM would come down to the normal levels by about 3 months of the pregnancy, but in a significant number of people, the IgM remains positive for as long as 8 to 10 years. So just finding the IgM is not an indication that this person has a recent infection. Okay? So, sorry.
Yeah, so what would you be doing for confirming the diagnosis in this case?
To confirm the diagnosis, I will repeat the test after 2 weeks.
Yes.
To see whether IgG appear or the titer of the
after
IgM
3 to
also.
4 weeks. After 3 to 4 weeks, we are supposed to do the repeat testing. And then in this case, what may be the effect on fetus of rubella infection?
There will be a lot of CNS effects on the fetus, like microcephaly and eye effect like cataract, and there are effects on the heart, VSD and TOF, and sometimes hepatosplenomegaly also may be there, or hydrops, and SGR, early fetal intrauterine growth retardation.
Yeah, so is it an indication for termination? She has come to you at 13 weeks?
She's 13 weeks, and if rubella infection is there, and if we confirm after 3 to 4 weeks, then we can directly suggest her termination, and there is no need to do amniocentesis if infection is in first trimester, because of the high chances of transmission as well as high chances of affection of the baby.
Very true. So here amniocentesis, you do not actually need to wait till 18 weeks to do the amniocentesis. If you see that the infection, you are confirmed sort of that the infection has taken place in first trimester, this is a straightforward indication for MTP. So for first trimester rubella infection, MTP. If the lady has come to you late, then only you need to perform the amniocentesis, because as the pregnancy advances, the chances of risk of transmission decreases, right? Then the affection of baby also decreases. Later on, the chances of transmission may increase, but the affection of baby does not increase. So what is the role of vaccination? Is there any treatment available for rubella?
As such, it is a viral infection, no treatment available, and vaccine is there. So government is promoting a lot regarding this. MMR is being given to 9-10 years of the age also, and we get the opportunity when patient comes to non-pregnant state or postnatally or post-abortal status, then we should advise the patient with, we can do IgG testing, and then if it is negative, we can advise her rubella vaccine.
Very nice. So congenital rubella syndrome has been identified as the leading vaccine preventable cause of birth defects by WHO. That is very important, and since 2017 we have included this MMR in our universal vaccination program also. These are the recommendations on rubella vaccination. All women of childbearing age and or presenting for preconception counseling should be advised testing for rubella IgG at least. If she is non-immune, vaccination is to be done, and she should not conceive for next 1 month. Earlier it was 3 months, but nowadays the recommendations have changed and the pregnancy should not take place for next 1 month. Women who are found to be non-immune during pregnancy should be vaccinated immediately postpartum before discharge, and breastfeeding is not contraindicated though for those who are vaccinated with rubella vaccine. So this is
another message that I want to give you is that if a patient comes to you say around 16 weeks and you have reasons to suspect that this patient had a rubella infection and you have ordered the test, the results are there, please, the second message is that please feel free to communicate if you are not doing the level 3 USG with your sonologist, and let him know that I am suspecting that this lady had rubella in the first trimester. Gives him an opportunity to be more attentive and to pick out maybe small things which he would have otherwise missed. So every time there is a suspicion of infection, first, as a medico-legal advisor, it is always good to talk to the patient than not to talk to the patient thinking that she is going to be stressed out. Tell her that I have reasons to think that this may be so and so. Put it on records and communicate with your sonologist that you do have reasons to believe that this lady had first trimester rubella. Okay?
Yeah, so our next case is for Dr. Deepika Devani. The case is, she is a 26 years old primey with 16 weeks, reports with a torch testing showing CMV, IgG and IgM positive with a history of fever with malaria a month back. So what are the risk of transmission or affection of the baby here, and what is the role of amniocentesis?
Ma'am, CMV is one of the most lethal virus among the torch panel. It has high risk of transmission, and affection is less likely in first trimester, but when affected, the effect on the baby is the maximum. It again causes sensory neural hearing loss as well as cerebral affection. So the test of choice to detect CMV or to be confirmatory is amniocentesis, and by doing amniocentesis we would do a polymerase chain reaction at say about 20 weeks for her.
Is there something else also you would like to know about the infection?
Ma'am, before subjecting her
you
to...
can see the slide.
Ma'am, before subjecting her to amniocentesis, we would do a detailed anomaly scan and would see for features of CMV affection like again ventriculomegaly, periventricular calcification, cardiac defects, echogenic bowel.
and if the antibody patient permits, then IgM along with specifically low avidity IgG.
Yeah, so I wanted to actually take out that what is the importance of identifying whether patient is having primary infection or reinfection.
Yes,
would there be a difference in management?
Ma'am, primary infection is more lethal and it will have more adverse fetal outcomes. Therefore, IgM with a definitive low avidity IgG would be of utmost help.
And how would it change your management or counseling? If it is a reinfection, say, then would the management or counseling change?
Ma'am, patient would be counseled that risk of transmission is as less as 1 to 3%.
Exactly. Exactly. So that is going to help you in going to help the patient to decide whether she should terminate this pregnancy or not. That is very important actually, and whether you should go ahead with amniocentesis, further management, further counseling. So that way it affects the management and counseling both, right?
I was just going through some literature, and there they have said, some studies have started saying that there may not be any significant difference between fetal affection vis-a-vis CMV1 and CMV2. Now we'll have to wait and see, because if that happens, in that case, then CMV2 becomes as bad as CMV1.
So this slide shows that how to differentiate between the primary and the reinfection. You can take a photograph of this slide. It is actually useful in clinical practice. Yeah. So next is the role of USG and amniocentesis. It is same for all the torch infections. Whenever there are sonographic markers, yeah. So what would be the USG markers here?
The USG markers from head to toe start from ventriculomegaly, periventricular calcification, microcephaly, periventricular calcifications. Specific is periventricular calcification for CMV. Then cardiac anomalies, hepatomegaly, echogenic bowel, and later
That's it.
So placentomegaly as well.
Okay, right. So are they going to help you in counseling the patient further?
Yes, ma'am, because definitive whatever brain affection has happened will later affect the neonatal infant and thereby adult.
Yes, it actually decides the severity of infection. If the presence of markers is more, then it tells that the infection is severe and baby may also get infected severely, and that may be an indication for termination again.
And CMV, by the way, is the most important non-immune cause of non-immune hydrops.
Yeah.
So whenever you have non-immune hydrops and you are interested in finding the reason, then maybe even if the baby could not be salvaged, you can go back and get that test done.
Yes.
Okay?
Yes.
Yes. And the other thing, cordocentesis is a very useful test to know the this viral load. That also can help you in deciding the further management. So is there any treatment available for CMV? As of now, there are studies going on the use of gencyclovir and valacyclovir and even the immunoglobulins, but as of now there is no treatment. Neonate needs to be followed up very closely actually, because 90% of them would be asymptomatic and the symptoms will be present only later on. So now we come to the case 5. This is to Dr. Shelja Soni, a gravida 2 para 1 L1 with 29 weeks pregnancy, comes with an USG showing fetus ascites and placentomegaly along with TR, tricuspid regurgitation, and cardiac wall dysfunction, basically features of cardiac failure. On investigation, blood group is O positive and no other organic cause is found. What may be the possible diagnosis?
As this patient, the blood group is especially mentioned here. The blood group is positive, and the features of cardiac dysfunction and cardiac failure and ascites and placentomegaly only. This is going in the viral infection like parvovirus infection, and here the features are placentomegaly and myocarditis, cardiac wall dysfunctions, and the hydrops ultimately because of the anemia, and the anemia which is because of the erythrocytosis poiesis is affected here, and this is the mostly likely a parvovirus infection.
After this conference, I am also going to get an ICT done before going for all this. Is it right?
So the third take-home message is parvovirus infection is a very important cause of non-immune hydrops. If you do not find any organic cause, all other tests are negative, the lady is Rh positive, please perform a parvovirus test. Khatam kar rahe hain. And the definitive diagnosis is by chordocentesis, by measuring the hemoglobin, and that is your treatment also by intrauterine blood transfusion. And generally in parvovirus infection, only one intrauterine transfusion is good enough, and it is the only infection when there are no defects in the baby, and it is totally treatable.
There is no structural abnormality.
Exactly.
Then we can treat the patient.
Exactly. So, as sir has asked to rush, so this is the last question from Dr. Trisha Nayak, and the question is, this lady is gravida 3 para 2 L2 with 38 weeks pregnancy, comes to LR with labor pains. On examination, papillary ulcers are present across introitus and lower part of vagina, which are tender on touch. What is the diagnosis? Is lab diagnosis necessary?
Ma'am, the presence of papillary ulcers along with which are tender on touch, my probable diagnosis is of herpes simplex virus.
Yeah, there is no other diagnosis which comes to mind. We see them in gynae OPD on day-to-day basis. So what is is lab diagnosis required here?
Ma'am, for management of patient, because
that we may do later on. She is in labor.
But for it will not change my. I would do the test, but it will not change my management for mother.
Exactly.
But it will help me in management of neonate.
Right. So what would be the obstetrics management?
Ma'am, obstetric management, since intrapartum transfer is high, the risk of transmission is high, so I would advise cesarean section, and there is active lesion.
So this is the only infection which alters your management, your obstetrics management, and it is an indication.
And always take a history. Is this the first time she is getting those papules, or she has been getting those papules? Because if this is a recurrent herpes, then the chances of transmission is way lower than if it's the first time she's getting those papules. That's an important
So all the
message.
cases have been done. I have only 2 slides because I really developed a thought in my mind while preparing this PPT. Is it the right time for universal screening, like doing the torch test in all pregnant women? We take all our data from the Western countries. In France, actually, they have a high prevalence of toxo and CMV, so they do it on a regular basis for all patients. But we say no, it should not be done. But why it shouldn't be done? We have enough data now, at least for the CMV, to do a universal screening for all pregnant women. This would be my fifth take-home message. Please read it, and you will also understand that it is the right time that we do the CMV in all pregnant women, because CMV has a long-term neurological sequelae for the baby. So to prevent that, it is the right time. We have enough data from India also, and there are many studies going on worldwide. Here there is a very nice scheme that is running in Kerala state, that is Shalabham scheme. They do newborn screening for all newborns for the 4 Ds: birth defects, deficiency, diseases, and developmental delay. And it is totally government sponsored. So why to wait for the neonate to screen? Do it in pregnancy itself, right? At least for the disease which is prevalent in our population. And so this is a very good study. This project is available on net. It is still going on, and this is going to be my next thesis topic also for my students. So it is a high time to think that we should at least be considering universal CMV screening for all, apart from rubella, a CMV screening for all pregnant women. So thank you so much, sir. Can I conclude my slides? Yeah.
D'Pankar sir is so elated. Khatam ho raha hai.
So serology for diagnosis of maternal infection needs to be interpreted carefully. Serology, serology, serology. Please interpret it carefully. So serology for diagnosis of maternal infection needs to be interpreted carefully. Definite role of ultrasound in prediction and monitoring of congenital infection. Invasive testing should be done to confirm fetal infection, and no drug to prevent perinatal transmission of most congenital infections except for the toxoplasmosis. कुछ समझ नहीं आ रहा, स्पाइरामाइसिन शुरू कर दो at least. Prevention of infection is the mainstay for most of them. So my disclaimer is that some slides of presentation have been taken from internet but used only for educational purposes, and a very special thanks to Dr.D'Pankar Banerji and organizing team FetusCon2024. And my co-moderator Geeta Guin madam for being with me.
Thank you. Thank you all the panelists for being wonderful panelists. Thank you, D'Pankar sir.
Thank you, Dr. Geeta.
I'll request
Dr.
all
Beena.
the panelists to please stay on the stage, and will request moderators to felicitate the panelists.
Thank you, Beena ma'am and Gunin ma'am for this beautiful panel. And आप लोगों को जितना सुने कम है, बहुत कुछ जानने को था, but due to shortage of time, ये पैनल जल्दी खत्म हो रहा है. अभी तो हम बहुत कुछ जान सकते थे आप लोगों से. Thank you for this beautiful panel.
Such a kind gesture from our wonderful teachers. Really thankful.
रुको ना सबर तो ले मेरे भाई.
इतना जल्दी छतरी आनी नहीं जाएगी.
आपको जल्दी है ना.
Chairperson of the Medicine Committee. A warm welcome from the Foxy leadership, our President Dr. D'Pankar, Secretary General Dr. Madhuri Banerji, our Vice President in charge Dr. Dinesh, and the Jabalpur Society for this wonderful celebration of World Fetus Day. I really must appreciate and thank Dr. Banerji for this wonderful concept of World Fetus Day, which is celebrated on the 31st of October every year. And every year Dr. Banerji arranges wonderful CMEs with excellent faculty. This time as well we have an excellent faculty, Dr. Vivek Krishnan and other esteemed faculty, and I'm sure you're going to have a great academic feast. Apologies for my absence because I'm out of the country, but I'm sure you will have a great time listening to all the experts on this wonderful day of World Fetus Day. Thank you and welcome once again.
Wonderful gesture, Madam,
पद्मासना
मैडम जॉब है आई.
या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा. शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहा. हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता.
जल्दी आओ.
पूरा नहीं हो सकता.
इधर के फोटो ले रहे हैं हम लोग क्यों नहीं आए? चलेगा
डॉपलर है क्या इसमें?
हाँ खड़े 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 अरे आप दो 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 मैम थैंक यू बहुत अच्छा हुआ पैनल
दीप्ति
आशिता का सामने नाम नहीं लिखा
और कौन बचा हो गया ना
ना आई रिक्वेस्ट
सब कोई आई रिक्वेस्ट एवरीबॉडी प्लीज कम इट विल बी अ मेमोरेबल फोटोग्राफ विदाउट एनी हेजिटेशन जो भी बैठे हैं चले आइए इधर
तुमको अलग से इनविटेशन चाहिए माहिश मांगी इधर आगे आ जाओ यस
दे दीजिए सबको मिशा जी बुक पास कर दीजिए मिशा जी एक बुक दे दीजिए
हो गया जल्दी करो
First of all, I would like to thank D'Pankar for floating this idea all over 15th year, and because of him we are getting to hear such good people and our old concepts are changing. Nahi, it's our great privilege. And this particular session is, the first speaker is Abhishek Goswami on 3D, 4D ultrasound. Is it living up to its promise? 2D tak theek tha, 3 hua, 4D hua, now it's 5D, you know.
Yeah, I'm 60
how many Ds are going to be added? I don't know. How many numbers are going to be added to the D?
God knows, ma'am.
I know.
In the way technology is progressing, you don't know.
I know. We don't know what is going to happen.
Absolutely.
So we welcome you.
Thank you.
Last year also I heard you and you're excellent speaker.
Thank you so much. Yeah. So good afternoon, everyone. Hope all of you are having a wonderful, enlightening session with luminaries like Vivek sir and Alkesh here. They are actually lightening up the whole thing. And D'Pankar sir, thank you for everything. It really takes a lot of effort to put up this show every year. और सर आपकी शर्ट बहुत अच्छी लग रही है.
Casual look in spite of being so busy since last so many days.
So the topic I am going to discuss today is about significance of 3D in current scenario and whether it has really lived up to the expectations or not. So before starting out, let me begin by saying that now 3D is no more an option. It is a necessity for a good ultrasound imaging, especially in fetal medicine, gynecological evaluation, infertility scanning. You need to have a good 3D machine with you to get good results. So before going into the specifics, I'll just touch upon the technicalities of 3D scan. 3D is nothing but acquisition of data in volumes. You have this raw set of data with you, which you manipulate with certain tools which are available at your machine and to get the desired results. So basically volume acquisition is of 3 types. First is 3D static, then the real-time 4D and stick imaging. 3D is a static image, and because it is a static image, the amount of information present in a 3D static image is much more than in a 4D. 4D is good for showing beautiful faces and body parts to the parents, but when it comes to the crux of the matter, if you want to go into a detailed investigation, you need a good 3D volume rendered image to get in details. So how really 3D helps? First thing first, multiplanar views in 2D scanning, multiplanar views are very difficult. You can get one or maybe two. The 3-dimensional view is very difficult to get on 2D. And then you also get this depth perception in 3D. Then there is much better demonstration of abnormalities. And once you have gotten used to using 3D, the patient throughput also increases. You need a lot lesser time to evaluate patient in details. And the favorite part is you can always store this data and you can revisit it. It's a great learning tool also. You can do all the kind of post-processing after you have stored the data. So what are the basic tools which are there for manipulating this data which you have stored? So this is first is the render mode, the multiplanar view, the VCI, TI and Omni view. I'll just very shortly touch upon this. So this is the flag bearer of 3D. Look at this wonderful images and it makes your profession glamorous. The patients come to you to basically see these images, but this is just about 10% of what actually 3D stands for. The next is the multiplanar viewing. This is simultaneous visualization of anatomy or a pathology in all the 3 dimensions. It gives you excellent anatomical details. Volume contrasting imaging is nothing but a summation of multiple slices, which then gives you a much more detailed information. Because multiple slices are summated in one image, the data that is there in one single image is much more than a routine 2D scan. So, okay, sorry. Then TUI is nothing like, it's just about cutting the slices from a raw data just as you do in a CT scan. OmniView is the latest edition and it is actually very effective addition to the tools because it can be used in very difficult planes. For example, if you have got a mid-pose uterus and you are unable to get the simultaneous 3D planes, so you just draw a line across the endometrium in OmniView and you get all the other 3D planes along with the normal 2D plane. And also you can use these tools in combination with each other to get some excellent images. So let me just begin with now specifics. I'll first discuss how 3D is important in gynecological investigation, that too especially for infertility. So first is abnormal anatomy of uterus. For describing in detail anatomy of uterus, you need to have a 3D image. You cannot confidently comment on anatomy of uterus on a 2D scan. So you need to have a good 3D evaluation. Now these are some of the various abnormalities which you often see on your day-to-day scanning. But the problem with this is that over the years, there has been a lot of overlap in the terminology that has been used for describing the various abnormalities. So ISHRI came up with this classification in 2015, and I recommend every one of you should actually go through this classification, and I think all of us should start using this classification because it sort of removes a lot of terminologies which were very ambiguous. So it's beyond the scope of the talk to really go into detail of ISHRI classification, but basically what they have done is they have divided uterine abnormality into 6 classes, and this is what is new. Now I think all of you should take a look at this. Now we don't use the term arcuate uterus. Uterus diadelphys is not used anywhere. Bicornuate is now known as bicorporeal uterus. Unicornuate is known as hemiuterus now. The T-shaped uterus is now known as dysmorphic uterus. And there is a 6th category in this classification which is known as not yet classified new category, where you put all the other things which you have actually not come across. And there are some new concepts which have been introduced, like myometrial wall thickness. So I won't go into detail, but I'll demonstrate it with just one example. Earlier, what used to happen was whether the uterus is septate or not, when there was a small septum, it was a very difficult kind of diagnosis. Now this classification has come with very specific definition of a septum. What they say is you draw a line across the top of the cornu, and you measure the above distance and the indented distance. So now if this indentation is more than 50% of this thickness, it's called a septum. So the definition of septum has now actually become very clear. You have got these wonderful new rendering modes in 3D where you can actually delineate the anatomy beautifully. So now we come to uterine cavity evaluation. Now when you evaluate a cavity, basically you look for 3 or 4 things: the shape of the cavity, the endomyometrial demarcation, and whether there is a disease present in the cavity or not. So this is how you can actually achieve such images. You can see how beautifully the endomyometrial demarcation is maintained here. There is no lesion inside the cavity, and see how beautifully fallopian tubes are coming out of the cornu. These are some of the abnormalities of the cavity. You can see additions of varying range. This is a small addition. Here you see almost partial cavity is lost. Here there is complete loss of cavity. And this particular image is very pathognomic of a certain disease, that is tuberculosis. You see this vertical going up of the fallopian tube, which is quite classical for tuberculosis. Polyps can be nicely demonstrated on a 3D image. You can actually get the correct location of the polyps. For example, these two are the fundal polyps. This one is a cervical polyp here. Now, this was a very interesting case. It was reported as RPOC from somewhere, and it had a failed evacuation also. And then she had come back, so I decided to put in some saline, and what I got was a polyp jetting into the cavity, and this was not actually an RPOC. Again, volume of the endometrium can only be evaluated on 3D. You cannot do it on 2D. And it is said that if the volume is less than 1.6 ml, but it is very unlikely that the mother would get pregnant. Now, fibroid mapping is once again a very important aspect. You are all familiar with this FIGO classification. Submucosal fibroids are really easy to demonstrate on a 3D scan. But when we come to myometrial imaging fibroid, it is not that well developed. So now they have come up with this intramural fibroid mapping. This is a new software. It is available only in high-end machines. Expert22 has come up with this. They have come up with this software. So what you can do is actually you can also, see demarcate the exact location of the fibroid. So it is very helpful for the gynecologist to operate upon them. This is fibroid mapping software. This is the fibroid. This red thing is the fibroid inside the uterus. Yes. No. This is coming only with Expert22. So these are kind of, this is how you can actually map a fibroid by this software. Sono AVC, again, a very, very useful application. Does not work very well with lower end machines, but in higher end machines, its performance is pretty good. And it is very effective in IVF patients because you cannot manually count so many follicles. Now, location of IUCD best described on 3D. You can see this is a Mirena in the cervix. This is a normally placed Mirena. And of course, pelvic floor imaging, you cannot do it without a good 3D, but I will not go into the details of pelvic floor imaging now. Now, coming to the obstetric applications. Now, over the years, the most glamorous part of 3D imaging was showing the face to the mother and other body parts. But trust me, it is just 10% of the whole 3D. And recently, I met a friend from Ahmedabad. So he told me that now they are doing a whole intrauterine photo shoot. They are preparing actually albums of the baby by using this machine, and I think it's an inspiration for all of you sitting at the back. You can buy a good machine and do a good photo album and sell it for 20,000, 30,000. They are charging something in the range of 30,000 for a good intrauterine this thing. So So now let's come to what we can see in 6 to 9 weeks. The first thing first, you first try and locate where is actually the sac. And as you can see here, this is an ischemic pregnancy. This one was an angular pregnancy. This has a fairer chance of growing up. And this was an scar ectopic, which you can see here. Then again, now with the silhouette mode, you can actually see development of brain in between 6 to 9 weeks. But not a lot of data is right now available with us to actually go into the anatomical abnormalities right now. But I am sure with time, people are going to diagnose quite a few things, maybe this early also. Now let's come to head and face. This was a case of anencephaly. You can see this was only about 9 weeks, and I could diagnose this at 9 weeks. Earlier this was not possible before 11 to 12 weeks. These are some other cases of anencephaly. Now rotation is a technical aspect of 3D. Sometimes you get faces like this. It is very difficult to image. It's not possible to really get a profile view. So all you need to do is take a good 3D and generate a 3D, and then you rotate it in all axes, and you will come across these micrognathia. And sometimes the face profile is very pathognomic of a syndrome. So this was a patient, this was only about 13 weeks baby. And you can see this is very pathognomic of a particular syndrome, which is known as Pierre-Robin sequence. So this baby was diagnosed at 13 weeks. TUI is very effective for diagnosing clefts, fine little clefts. If you've got a cleft lip and you are looking for a cleft palate, use of TUI can help you a lot. Then of course lips. Now the current ISUOG guidelines say that you have to look for lips in the first trimester, but on a routine 2D scan, looking at a lip is really difficult. So what I do is when I suspect something, I usually go for the 3D to look for lips. Now this was a very difficult case. It was actually a googly to me. I couldn't see the lips, so I decided to do a 3D scan, and there was something wrong in the profile view. So I took this. You can see the lips are well developed. The premaxillary triangle, you can see it is well formed. But then when you go into the profile view, you see here there is a complete loss of secondary palate. Basically, there is no palate here. So this is a very rare case where the lips are there. I mean, the primary palate and lips develop separately, and the secondary palate develops separately. So there is absence of secondary palate in this. So this was a very rare case. It was picked up at 11 weeks, 4 days. Now, for CNS evaluation, 3D is really a boon. You cannot do anything without a good 3D. You cannot do a detailed neurosonogram without a good 3D. So all you need is a good standard transverse section. You take a high quality sweep and just press a button, and you can get such wonderful images where you can do a detailed neurosonogram just in one touch of a button. Then again, location, exact identification of location of any anomaly, any pathology in the brain can be best demonstrated by 3D images. Now, posterior fossa cysts, as we all know, all the angles that we need to measure, they have to be on a sagittal, mid-sagittal scan. So, like in this case, this was a Dandy-Walker malformation, and the cyst, and there's an elevated tentorium, and the vermis is upturned. You can very confidently demonstrate this on a 3D. It is actually difficult on 2D. It becomes very easy on 3D. And this is a surface rendered image. You can actually, this cyst was protruding out through the occiput also. And this was actually that rent from which this cyst was also protruding. Sometimes, like in holoporencephaly cases, you also have facial anomalies associated, and so to get the full picture, you need a good 3D. For like in this case, this was a lobar holoporencephaly with a cyclops. This was a case of bilateral cleft with holoporencephaly. And of course, the first trimester years, although they are not a part of the protocol in ISAG guidelines, but they are associated with lot of syndromes. So evaluation of ears is actually low set ears. If you want to diagnose, you need to have 3D image for that. You cannot do it on 2D image. It is very difficult. Now we come to spine and thorax. So rib counting in first trimester, even in second trimester, it can be best done by 3D images also. You cannot do it on 2D. And look how wonderfully, I think this was 12 weeks, and you can see, you can wonderfully count all the ribs on either side. This was a skeletal deformity which was there, so a 20-weeker. So then thoracic sequestration, you can actually pinpoint the location of the sequestrated segment by 3D imaging. Spine evaluation, because spine is a curved surface, so it is usually difficult to get in one single image. So for this we can use this Omni view, curved Omni view, and you can get some wonderful images really. Now these were some cases of open spina bifida. You can see how confidently you can demonstrate the defect also. Coming to fetal heart, stick or TUI can both be used. I am not a big fan of stick or TUI. I don't use 3D on heart because of the fact that getting the fetus to the right position is difficult. Then the acquisition time is pretty high with the current probes. It requires almost 15 seconds of a scan, a still baby, to get a good 4D, 3D volume. With upcoming electronic probes, the time has significantly reduced now. Now a sweep can be completed even in 2.5 seconds. So but they are very, very costly, extremely costly right now. So I think there is still time when you can actually use 3D confidently on a. But one thing is for sure, if you have got just one good stick image with you, volume with you, it's a great learning curve. It is a great tool to learn heart, because you can simultaneously get, you can see the vessels in 3 planes. And so actually it helps you a lot to understand the anatomy of the heart. Let me come to the abdomen then. One specific point I would like to make, fetal kidneys in first trimester are actually very difficult sometimes to imagine. But using a 3D and with VCI, almost all the time you can get kidneys, you can see kidneys at 12 weeks. At 12 weeks you will be able to image kidneys with using 3D and VCI imaging, which might not be possible on 2D sometimes. And then it also adds as an adjunct in abdomen. It's just an adjunct. It is not the mainstay of 2D imaging, but for abdominal pathologies, you can actually get these lovely images. For example, this was a case of omphalocele. This was gastroschisis. This was a case of body stalk anomaly. You can see a very short cord here. This was a pentrology of cantrils. You can see ectopia cardis here. The heart is coming into this, is being herniated into the sac. This was a case of megacystis. Then genitals. This is a very interesting case. I had it about a month back, and I could see this. You can see this. This looks like a female genitalia, but there's a cauliflower sign here, right? So I was little confused what it is. Is it clitoromegaly or what it is? I was not really sure. So I took this 3D, and look how beautifully you can see the labia, the fusion of the two. I mean, these kind of things you cannot actually confidently diagnose on 2D. And you can even see this micropenis here, right? This micropenis, you see the fusion, you see the two labia coming out. And this patient, and I also tried, because I was confused कि ये male है या female है, so I looked to the uterus, looked for the uterus also, and I could find this uterus here. So uterine bud was there. It is usually not possible on a scan, 2D scan. And then again, this was a case of hypospadias. Again, beautifully made out, confident. You can actually communicate it to the referring person that this is the case. And then for limbs, of course, 3D is a great asset. you can have these wonderful images, and you can show this off, you can flaunt your abilities, your machine technology to the patient. And for demonstration of skeletal dysplasia, like for example in this case, I gave it to a plastic surgeon, and he could counsel the patients that what time, at what, he said case at only after 16 years of age, he will be able to rectify this deformity. So these are some of the cases. So my take-home message would be, most of you who are sitting, your PG students, you should always start with a very good machine. Buy a good machine first, and then you start your practice. Invest in your knowledge, your machine, and not on cut practice. Sir, itna hi hai take home. Okay. So thank you so much for your patience.
Thank you, Dr. Abhishek. So the take-home message is a good machine and a good doctor operating the machine. Both are very, very equally important.